Good evening. I'm Dr. Vikashini, a DocTutorials faculty. Hi friends, good evening. I'm Dr. Vikashini, a DocTutorials faculty. So today we are going to discuss about the approach to a patient with cervical lymph node. So when a patient comes to the clinic or to the OP with a swelling in the neck, which is probably a cervical lymph node, how do you approach, how do you take the patient in a further management? So first, what is the definition for cervical lymphadenopathy? The definition is just it's the enlargement. It's nothing but enlargement of the lymph nodes in the neck region, and it is not all enlarged lymph nodes are significant. So if it is more than 1 centimeter, then it becomes a clinically significant lymph node. So that is cervical lymphadenopathy. Now, say for example, a 42-year-old male presents with a painless neck swelling for 3 months, and there is no fever, there is no history of pain. Now, what is the approach? Whether you proceed considering it is an infection, or whether it is a TB or is a lymphoma or a secondary snake, whether it's a metastasis. So how do you approach it? For which you need to know the different causes of lymphadenopathy. So broadly, it can be classified. The causes can be classified as either inflammatory or a neoplastic. And further, the subdivisions for the inflammatory causes are whether it's acute or chronic. So the acute inflammatory causes of lymphadenopathy, cervical lymphadenopathy, are the tonsillitis or pharyngitis. So whenever a patient complains of a painful swelling in the neck, so there is a painful neck node, then always look for the oral cavity, look for any pharyngitis, or parotitis, or dental caries are present, which eventually will develop an abscess, dental abscess, or any other head and neck infections like dandruff, like elicit a history of any dandruff is present or not, or something like that. And these are the acute causes. Now, coming to the chronic inflammatory causes of a lymphadenopathy, now you need to think in terms of tuberculosis, syphilis, sarcoidosis, and histiocytosis. Whereas coming to neoplasty, it could be either primary or a secondary from any other primary. So the primary cause for the cervical lymphadenopathy could be Hodgkin's or non-Hodgkin's lymphoma. Whereas the secondary causes, the primary can be from if it is a secondary neck node, then you need to look for the primaries, some other lesion in the oral cavity or in general head and neck cancers, or the salivary gland tumors or hypopharynx ulcers, or adenocarcinomas arising from the glands like thyroid, breast, or the malignancies from lung or any other viscera. Say, for example, gastric malignancies which present with a supraclavicular lymph node, which is Virchow's node. So these are the broad classification of causes for the cervical lymphadenopathy. Further, the classification can again be done based on the pain. So if a patient comes with a painful neck node, or whether there is a pain or it's tender or non-tender. If it is tender, then think in terms of acute inflammatory. But if it is non-tender, it could be either chronic inflammatory like TB or a malignancy. Again, it can be classified based on the number of lymph nodes present. If it is single, it can be either single or multiple. If it is single, then think in terms of metastatic. If there are multiple lymph nodes present, then it can be further subdivided into either a discrete lymph node, discrete multiple, or matted together. If it is discrete, then it's probably a lymphoma. If it's matted, then it's no doubt it's tuberculosis. Again, based on consistency, if whether like on palpation, if it is soft, it could be a reactive, that is inflammatory. If it is firm or rubbery, then it is definitely a lymphoma. If it's hard, then yeah, it's secondary snake. And based on mobility, it could be either mobile or fixed. Mobile in case of benign or early diseases, early malignancies will be mobile. Fixed in case of malignancies. Now coming to the nodes, which level of lymph nodes? So, in general, there are seven levels of neck nodes present, and these are all just a brusher. You know all this. So, 1A is submental, 1B is submandibular, and 2, 3, 4 are upper, middle, and lower jugular, and 5 is anterior triangle lymph nodes, and 6 is the central compartment, including pre-tracheal and pre-laryngeal or delphian lymph nodes, and superior mediastinal is level 7 lymph node. So this is the anatomical, surgical anatomy showing the level 1 lymph node, which is submandible and submental. And this is nothing but 2, 3, 4, and nothing but which runs along the internal jugular vein. So upper one third, middle jugular, and lower one third is lower jugular. And yes, this is level 5 anterior triangle. Now, what will be the order of palpation? You always start the palpation from the submental region, proceeding towards, proceeding towards submental, submandibular, and followed by pre-auricular, that is in front of the ears, and post-auricular behind the ears, and next in the occiput region, the scalp region, and occipital region, followed by the triangle, anterior triangle and the posterior triangle lymph nodes, and then coming down to the supraclavicular region, and then the superior mediastinal lymph nodes. So this is the order of palpation you'll be starting and doing in the patients. So start with submental, go laterally submandibular, then in the preauricular, complete the face, preauricular, postauricular, and complete the scalp and head and neck region, and then come back to the lower neck, central compartment, and the lower neck region. Now, what is the importance of knowing the levels? Because according to the levels, certain all these particular levels will be training particular anatomical structures. So, knowing the level of lymph node, you can directly point out to the anatomy which has been from which the pathology has origin from. So if there is enlargement of the level 1, 2, or 3 lymph nodes, probably the primary or the pathology will be in the oral cavity, including the lips. And the lips, the upper lip like malignancies will they have a tendency to metastase. Initially, they metastase only to the ipsilateral side, like wherever the side of the lesion. So the particular side of the neck node will be involved. Whereas coming to the lower lip, the lower lip has a tendency to metastase to both ipsilateral and then contralateral, both sides. They can metastase to both sides. So that also you need to keep in mind. And if there is enlargement of level 2, 3, and 4 lymph nodes, and yes, which is upper jugular, middle jugular, and lower jugular, the primary pathology will be originating from the upper aerodigestive tract, which includes base of tongue, oropharynx, nasopharynx, and supraglottis larynx. And if there is an enlargement of level 5, probably the anatomy, the origin is from the scalp, ear, or the posterior facial skin. And 6 and 7, it's from the subglottic larynx or a thyroid malignancy or thyroid lesion, and a lesion or malignancy from the cervical esophagus. So if there are pathology in these anatomical structures, it leads to the enlargement of level 6 and 7. So that's the importance of knowing the levels. Now, we have a patient with swelling in the neck. Not any swelling cannot become a lymph node, but what are certain points can favor your diagnosis towards a lymph node? So first of all, you need to confirm whether the swelling is a lymph node or some other superficial swelling. That can be lipoma, which is a universal tumor that can also happen, that can also occur in any region, neck region, isn't it? So what are those diagnostic points in favor of lymph node? One is plane of the swelling. See, mostly all of these neck nodes are present deep to the deep cervical fascia. So that is a plane of the swelling. Next is shape of the swelling. Now, what is the normal shape of lymph node? It's a classical oval shape or a reniform, that's kidney shape. So that is a normal shape of lymph node. Now, what is this SI more than 0.5, which is nothing but shape index, which I'll be discussing in the next slide. So if the shape index is more than 0.5, then the normal lymph node has lost its classic oval shape and has become round in shape. So therefore, it points more towards malignant lymph node. So you need to think that if the shape index is more than 0.5, then it's pointing towards malignancy. So further evaluation have to be done. So these are the most important diagnostic points that favor the swelling could be a lymph node. One is a plane, which is deep to deep cervical fascia. With a few exceptions, almost all the neck nodes are present deep to the deep cervical fascia. And shape of the swelling, which is normal lymph node is oval. When it becomes a malignant, it becomes round in shape with shape index more than 5. And what is the significance of? As I already mentioned in the first slide, not all enlarged lymph nodes are significant. It becomes significant according to the region. So in the cervical region, it becomes clinically significant if it is more than 1 centimeter, and especially for the level 2 lymph nodes, because these level 2 mostly drains the oral cavity, which is not very hygiene, right? So the level 2 lymph nodes, it becomes hygiene only it becomes clinically significant only if it is more than 1.5 centimeter. The same goes for the axillary region. So any axillary lymph node is significant only if it is more than 1.5 centimeter. And for the inguinal region, which drains the, yeah, some patients, most people walk with a barefoot, and the genitals, all these are non-hygienic areas. So in those regions, normally any individual will be having a 1.5 centimeter enlarged lymph node. But when does it become significant? Which means like only if it is more than 2 centimeter, particularly in the inguinal region, then it becomes significant. So coming to say, whenever you write a case sheet, the first point, the first thing in the clinical examination after this conscious oriented is you'll look for the pickle, right? Like pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema. So what is it? It's not just lymphadenopathy; it's generalized lymphadenopathy present or not. So what is the definition? when do you call it as a generalized lymph node? Only when two or more group of lymph node is involved, it's called as generalized lymphadenopathy. Say for example, if a patient is having a supraclavicular lymph node and submandibular lymph node, it doesn't. Both these lymph nodes belong to the cervical group. It's just one group, but two multiple multiple nodes are present, but they all belong to single group. Two or more groups should be involved, which means if a patient is having a supraclavicular lymph node and an axillary lymph node, so two groups are involved. There can be three also. There can be inguinal lymph node also, enlargement also. So if two or more groups which are non-continuous, which are not in continuity is involved, then that's called as generalized lymph node. So these are certain specific points you need to know while writing a case sheet. Now, as I already mentioned, we'll discuss what's the shape index. So this is the ultrasound showing normal classic oval shaped or kidney shaped uh, lymph node. So see here the long axis, this is the long axis and this is the short axis. So the long axis is two times that of the short axis. So that gives the classic oval shape to any normal lymph node. Now what is the shape index? It's nothing but the ratio between the short axis and the long axis. So if the short axis is 1, then 2 times of short axis is long axis. So 1 is to 2. So the shape index normal is 1 is to 2. So what is the shape index normal value? It's 0.5. If it is more than 0.5, which means the short axis diameter enlarges. The short axis diameter enlarges, then it loses its normal oval shape and becomes round shape. So if the shape index is more than 0.5, it becomes round shaped lymph node and it points more towards malignancy. That's why it's called like most of the time you'll be heard like any malignancy is nothing but malignant lymph node is nothing but taller than wider, which means the short axis has grown in size, grown in diameter. In that way, in such a way that the shape index is more than 0.5. Got it. So this is again ultrasound normal showing an ultrasound showing a normal lymph node with this kidney shaped with a normal fatty hilum in the center. And this is a round shaped malignant lymph node, abnormal lymph node with loss of fatty hilum. So what is the hilum? Hilum is a place where the blood vessels enter, right? So this is a color Doppler showing a normal lymph node with blood flow in the hilar region, whereas this is the abnormal lymph node where you can see there is a peripheral blood flow. There is a loss of fatty hilum, right? So it retrieves the blood supply from the surrounding structures. That's the reason for the peripheral blood flow. So this is the abnormal, the color Doppler showing abnormal lymph node with peripheral blood flow. Yes. So these are the basic, some specific significant points to how to approach a patient with cervical lymph node. Now I'll give you some important points. We'll discuss some important points about tubercular cervical lymph nodes. So this is the this is a case showing tubercular cervical lymph node. Now the case format goes like you'll be as usual eliciting the history of swelling in which side of the neck, whether it's associated with pain or not, and there will be an evening rise of temperature if it is a TB case, and associatedly there will be cough with expectoration and all those B symptoms like malaise, fever, night sweats, loss of weight, loss of appetite, all this will be present in case of adults. But in case of children, there will be an additional history of failure to thrive or failure to grow. Got it? So this is how the case format goes. Coming to the clinical part, examination part, you look for the size, shape, number, all this you'll be doing. I don't want to waste much of the time here. I'll just highlight a few important points. So, what are the specific characters of a TB lymph node? The TB lymph node, as we already discussed, like how to classify the swelling or the lymph node based on the pain, based on mobility, based on consistency. So, here the TB lymph node will be firm and it is non-tender. See, firm, soft is reactive, firm or rubbery is lymphoma or any other benign chronic lesions. Hard is malignancy. So this is a chronic lesion, so TB. So this is firm in consistency and it's non-tender. And there will be multiple matted lymph nodes which are mobile. So all these points will favor the diagnosis towards tuberculous lymph node. And also you need to look for the lymph node in the other regions like axilla and inguinal region in both sides. There are 5 stages of suppuration in the cervical TB lymphadenitis. So the first stage is just an enlargement. So here see, first stage is just an enlargement of the cervical lymph node. So which will be, as I already discussed, the characteristics. It will be firm, non-tender, matted, or like firm, non-tender, and it's a mobile swelling. Now the second stage is matted lymph node. Now how does the stages progress is that there will be initially enlargement of the lymph node and that there will be certain inflammation surrounding that single particular lymph node. So that's called as periadenitis. Since there is an inflammation surrounding this single lymph node, it also involves the neighboring lymph nodes. So multiple lymph nodes will get attached together, and that forms a matted lymph. So in that way, they become matted. And if it's not treated, if it's not identified even in this stage, then this multiple necrotic lymph nodes, matted lymph nodes, they coalesce to form together a cold abscess. So why it is called as cold abscess? Because there is a caseating pusticious material in this, because it is nothing but the multiple necrotic lymph nodes which coalesce to form the abscess thing, right? So there will be pusticious material present, but there is no formed present in this, because any inflammation, there will be five signs, right? Ruber, dollar, Kaller, tumor, all this. In that, it doesn't, like, it lacks that warmth. It is not warm. So like, any abscess should be warm, right? Warm and tender, but it is not warm. Since it lacks that sign of inflammation, it's called as cold abscess, and if it is left untreated in this stage, it will progress. This cold abscess, see, all lymph nodes, what is the plane of the lymph node? Any lymph node, it's deep to deep cervical fascia. So all these lymph nodes, which are present deep to deep cervical fascia, if it is left untreated in this stage of cold abscess, they'll burst open, and now burst open through the deep cervical fascia. See, if it is left untreated, nature has its own way of healing. So what the nature do? It tries to push the infective material out of the body. Posteriorly, there is cervical vertebra, which is very hard. So always the giving away will happen only in the weak area, which is anterior. There is skin, soft tissue. So what happens? The lymph nodes, the abscess which is present deep to deep cervical fascia, bursts open or bursts through this fascia and come to lie in space just below the skin. And that stage is called as collared abscess. Now it is a bilocular mass. There is half of the posterior material will be present deep to deep cervical fascia, the rest will be present superficial to the deep fascia. That is just below the skin. So it's a bilocular mass with cross fluctuation positive. If it is again left untreated in this collared abscess, then there's nothing to burst open here. It's only the skin. So it bursts open through the skin with a discharging sinus tract. And eventually, if even if this stage it's not treated, eventually it might ulcerate. So these are the stages. See, initially there is lymphadenitis, enlargement, lymphadenopathy, and lymphadenitis, which attracts or collects all the lymph nodes together, that becomes matter, and then they coalesce to form a single like cold abscess, coalesce to form a cold abscess, which lie deep to deep cervical fascia. Now that opens or bursts through the deep fascia and comes to lie just below the skin, and that is collared abscess. So that is a bilocular mass with cross fluctuation positive. And even at this stage, if it's not treated, then it opens up as a sinus tract. So these are the stages. And this is even this sinus formation, if it is again left untreated, again it might eventually ulcerate. And this is a classical or hallmark feature of any tuberculous ulcer, with that is tuberculous ulcer with undermined edges. So what is the reason for this undermined edge? Is that this tuberculous bacteria, it destroys the subcutaneous fat faster than the rest of the other tissues. So its subcutaneous fat is being destroyed by this mycobacterium faster than rest of the other soft tissues, and this bacteria comes to survive. It survives in after destroying the subcutaneous tissue. It survives there because it prefers to stay in a relatively anoxic environment, and that's the reason for this undermined edges. Okay. So that is all about the tubercular. Now coming to the management, so any management starts with investigation where there will be elevated ESR and CRP, and the hemoglobin will be reduced. And MATO test will be positive, which is an ancient test, and that's been superseded by this interferon gamma test. So here, what we do is an antigen, which is very similar to this mycobacteria, is used to stimulate and also to measure the quantity of interferons that being released by the cellular response or the T cells. So this interferon gamma. It actually measures the host's cellular immune response. So an antigen that is very similar to the mycobacterium is used to stimulate and also measure how much of this interferon gamma is released by the T cells. So in such way, this identifies also the latent and also subclinical TB. And the other conventional tests are doing a sputum culture sensitivity, but this results might take several weeks. And also sputum AFBC yields and technique staining has to be done. Pus also can be aspirated from cold abscess, but it's very thick. It will be very thick, but still there are techniques like that also. It's been done. Aspiration of pus from cold access can be done, and it's sent for CBNAT or culture or AFP. And even excision biopsy can be done, but it is done only in the early stage of adenitis when it is lying below the deep to deep cervical fascia. Even at the lymphadenopathy periadenitis, matted lymph node stage, you can also try the excision biopsy. And you also need to rule out investigation, like you need to perform investigations to rule out the systemic involvement. And treatment, the mainstay of treatment is antitubercular drug ATT, but this is done after confirmation with histopathology or stains or culture. When after confirmation, you can start ATT. So now that is all about the tuberculosis. Some highlights only I have mentioned. No, it doesn't cover the full tuberculosis. I'm just giving you the highlights, which is clinically relevant. Similarly, the highlights of lymphoma that is needed for the clinical highlights for the lymphoma we will discuss. Again, the history part, for tuberculosis, you'll be eliciting, there will be a evening rise of temperature, all those B symptoms will be there. Again, in lymphoma, there will be B symptoms like fever, night sweats, weight loss, pruritus, um, will be there. And there are two types of lymphoma, which are Hodgkin's and non-Hodgkin's. In the Hodgkin's, the classic Hodgkin type, it actually predominantly like classic type is the most predominant one. 90 to 95% of Hodgkins are classic type, and the other types are the nodular lymphocyte predominant type. Now, where does this classic type again can be classified as nodular sclerosis, lymphocyte rich, mixed cellularity, and lymphocyte depleted, and they actually arise from germinal center of the B cells, B cell precursor cells, and then it might transform into malignant Reed-Steinberg cells and also other Hodgkin cells. And it stains positive for the CD30 and 15, whereas CD30 and 15 are negative for this nodular lymphocyte predominant type, but instead CD20 is positive. Got it? And coming to the non-Hodgkin type, this actually arises from the precursor B cells and also mature precursor B and T cells and mature B and T cells. Not whereas this Hodgkin classic type arises from the B germinal center of B cell precursor cells. Non-Hodgkin arises from precursor B and T cells and mature B and T cells. And splenomegaly is more common in the non-Hodgkin type, not in the Hodgkin's type. And splenectomy is reserved only for the patients with symptomatic splenomegaly. Not for all splenomegaly, you can't do splenectomy. That is reserved only for the symptomatic patients like abdomen pain or early satiety, fullness, or something like that. Again, coming to the management investigation part, always investigations should start with non-invasive, like scanning, USG or CT or MRI or PET CT, and then followed by invasive type. So FNAC will do good, or like in case of non-lymphoproliferative disorders. So if, especially in secondary snake, it is very safe and it gives you an accurate uh, direction. So like in case of secondary, if you're suspicious towards secondary snake, then you can, if you do an FNAC, it will come out as either a metastatic deposit from squamous type or adenomatous type. If it comes as squamous type, it's very easy to search for the primary, like you'll be looking in that direction. Adenomatous means you need to look for the glands, like thyroid or breast or gastric. So it's very safe and accurate in case of non-lymphoproliferative disorders. But suppose you're planning to do a molecular analysis or any histochemistry, immunohistochemistry, such of other special stains. In such case, it will be okay if we get more of tissue, and that can that conditions or that cases you can go in for core needle biopsy. An excision biopsy, if you're strongly suspicious of lymphomas, lymphoproliferative disorder, you can directly go for excision biopsy. Or even for if you're suspicious of the early stage of TB lymph node also, you can go for excision biopsy. And PET CT, this actually identifies any lesion which has high metabolic, any lesion with high metabolic activity. And cancer or tumors are known to have a high metabolic activity, right? Because like more metabolic activity directly proportional with high uptake of fluorodeoxyglucose. So those lesions, if there are multiple lymph nodes, say for example, there are multiple lymph nodes in cervical, in axilla, in inguinal, and which node to be targeted for the excision biopsy. So that can be decided based on the PET CT. And treatment for the lymphoma, it's chemotherapy. Like we have regimens, CHOP regimens, and ARCH, rituximab, ARCH CHOP regimens, something like this. Chemotherapy plays that's the main way of treatment for the lymphomas. So again here, as I already mentioned, so if there are multiple lymph nodes, so this is the PET-CT showing uptake in the cervical region lymph node, and here you can see right axillary lymph node uptake here, and again this is the inguinal. You can see the pelvis, and yeah, this is the inguinal region lymph node uptake. So comparatively, like how do you target which lesion to be targeted for the excision biopsy? Is that uh, comparatively which lesion has the high standard uptake value. So compared to the cervical, axillary, and inguinal region, this inguinal region has the lymph nodes has the high metabolic activity. So the most abnormal lymph node should be targeted for the excision biopsy. So what is the most abnormal lymph node here? The one with the highest uptake, standard uptake value, SUV. So here in this case, it's the inguinal region. So this can be targeted for the excision biopsy. But as a rule, in general, the more superficial lymph nodes should be chosen for the excision biopsy when compared to the deep lesions or deep lymph nodes, because that is to avoid the surgical morbidity. So every selection, every decision have to be individualized to every individual patient. It's not a rule for everyone. Got it? So the highest uptake standard uptake value node has to be targeted, and more superficial, take everything into account, and according to your clinical scenario, and it's all your clinical decisions. So your decision should be more uh, correlation, should have more correlation with clinical examination also. So that completes the lymphoma, highlights of lymphoma. Now coming to the secondary snake. In secondary snake, you have three headings. There is known, either you know the primary, where the primary is arising from, with just a clinical examination part itself. And the second is unknown primary. See, primary is called as unknown primary until only the investigations or evaluations are done. Once an evaluation is being done, then you'll be able, like the primary, you'll be able to find out the primary, where the primary pathology is. So such condition, such pathology is called as unknown primary. That is before investigation part, unknown by clinical examination. What is this occult primary? Is that even after investigations like CT, MRI, endoscopy, even after performing all this, you're not able to find out the primary pathology, which means that condition only you will be labeling that condition as occult primary. But this term has been like usage of this term is decreasing because of the superseded investigations that are being invented, right? So PET-CT, it definitely will pick up the highest metabolic activity, lesion with highest metabolic activity. So, but just for your knowledge, I'm just describing the terms: known primary, unknown primary, and occult primary. So, known primary, probably the oral cavity or the thyroid, the head and neck, basal cell carcinomas in head and neck region, or squamous, any cutaneous lesions. All this, you need to go in search towards all these regions or anatomy. Unknown primary, mostly you will be able to identify it with the investigations. And in occult primary, usually the lesions or the primary pathology will be arising from the hidden areas, for which you need to do a blind biopsy. But this blind biopsy can be complemented or supplemented with PET-CT. So you do if your primary lesion is not being able to identify, you're not able to identify the primary lesion, then do a PET-CT, and with help of PET-CT, which highlights all those, yeah, there'll be uptake of FDG, right? So with the help of that, then the targeted biopsy. So this blind biopsy this term is completely obscene these days. Now it can be actually changed to a targeted biopsy. Got it? So still, let's in viva, some examiners might ask you what are those hidden areas, and what is a blind biopsy. The other name for the blind biopsy is surveillance biopsy. Now these are certain hidden areas like tonsils, tonsillar bed, base of tongue, piriform sinus, fossa of Rosenmuller, retromuller trigon adenoids, and subglottic regions. That is subglottic larynx. Yes, investigation strategy always to start with non-invasive, that is radiological. So to start with, it's ultrasound, and then you'll be whether it's a primary or a secondary, you'll be able to identify. So if it is a primary means, so that could be only two options. Primary means it's lymphoma. So if you're highly suspicious of lymphoma, go directly for excision biopsy. If you are suspecting it as a secondary, then which invasive investigation holds good for secondary? This we discussed already, right? So excision biopsy, you're highly suspicious of lymphoproliferative, go for excision biopsy. But which invasive investigation holds good for the secondary is FNAC. And from FNAC, you'll get to know whether it's a squamous or adenocarcinoma. If it turns out to be squamous, then search for the primary in these anatomical structures like oral cavity, larynx, nasopharynx. If it comes out as adenocarcinoma, then search for the primary in the thyroid, breast, or gastric malignancy. Yes, so this actually completes the overall approach. But in general, what are the things you need to know is that location. So depending on the location, you need to search for the primary tumor. If the lymph node is enlarged in the high cervical region, then look for the primary in the nasopharynx, tonsils, tongue, thyroid, larynx, face and scalp. That is head and neck. Low cervical lymph nodes. It could be like supraclavicular, something like that. It could be a pulmonary. The primary can be from pulmonary or intra-abdominal, mostly um, gastric malignancy, and that's called as Virchow's node, and that sign is called as Troisier sign. So Virchow's lymph node, yeah. Next is Virchow's lymph node, which is a left supraclavicular lymph node. Then you need to search for intra-abdominal malignancy, which is most probably gastric, or pelvic malignancies. Even ovarian tumors but, can present with the left supraclavicular lymph node enlargement. And axillary, again, it could be a breast or from upper extremities or trunk. Even left axillary lymph node enlargement can point towards intra-abdominal malignancy, and that's called as Irish lymph nodes. In gastric malignancy, these are the atypical presentations of gastric carcinoma. This Virchow's node, Irish node is left axillary lymph node. Virchow's node is left supraclavicular lymph node. So all this, they're all single points. Every single point can help you narrow down to a diagnosis or like most of the time they can direct you to the exact diagnosis. At least it will help you to narrow down the diagnosis. Got it. These are certain special characters or highlights. Inguinal, if there is an inguinal lymph node enlargement, search for the primary in the lower extremities, melanomas, cervix, genitals, vulva, endometrium, ovary, rectum, anus, and penis and the prostate. If there are pelvic lymph nodes enlarged in PET-CT or CECT, then look for the primary, the prostate, testes, or any gynecological organs or lower extremities. So that is all. So this is actually concise. This is a concise part. So these are the enlarged lymph nodes. Go in direction of like these are the anatomical structures you need to look for. Now I'll give you some examples. Try answering this. A 22-year-old female presented with matted lymph nodes. So what is the diagnosis? Just say young female. So it's very rare to be a malignancy at this young age. But there is another clinical glitch here. Matted lymph nodes. So it is a tuberculosis lymph node. So start eliciting history in that direction. Evening rise of temperature, cough with expectoration, fever, night sweats, loss of weight appetite, and look for other system involvement, all such things. Now coming to the next case simulation. A 65-year-old, so age. So your thought process should start once you ask the age itself. So 65, old enough to think of cancer, malignancy. And also, I added you have another risk factor here. Smoker, presented with single hard swelling. See how many clues are present in one single line. Old, elderly, smoker, single. Mostly single means either like it's a malignancy, early malignancy, right? So single and hard consistency, definitely malignancy. So it could be a secondary snake. Now search for the secondary snake in the oral cavity or something like cervical esophagus or something like that. That all we discussed, right? Next, third case simulation. A 30-year, so a middle-aged female with history of night sweats, which is a B symptoms. On examination, there is a multiple rubbery lymph node. So multiple rubbery. So multiple, it can be again it could be discrete or matted. So, rubbery lymph node. So you take the multiple one. So multiple discrete is lymphoma. Rubbery consistency again lymphoma. And a middle-aged female coming with B symptoms. One of the B symptoms is night sweat. So again, this could be a lymphoma. So this is how your thought process should be. It's all very simple. That's it. Okay, but not all enlarged lymph nodes should gain clinical significance or gains clinical attention. When they become alert, when they become alert is that only when these red flag features or alarming features are present, you need to jump into action to rule out malignancy or evaluate further. Got it. And what are those red flag features are? Those persistent lymph nodes. That is, the lymph nodes are present for more than 6 weeks, and they are despite giving antibiotics, it's not healing. Despite the time and treatment, It's always present, it's persistent for more than 6 weeks, and not only present, it's also progressing in size. These are all the red flag features, and it's hard and it's fixed. And supraclavicular location itself demands clinical attention. So it's called as tricuspid abdomen malignancy, which is gastric malignancy. It is which is associated with loss of appetite and loss of weight. So these are the red flag features you should gain clinical attention, and then you take the patient for further evaluation. So this is how your approach should be. I think I have concisely finished the topic. So this completes today's discussion. So thank you, friends. All the best.